Everyone. Welcome to the next webinar in our Work and Play in a Pandemic, Ethics and Occupational Health and Webinar series. We will wait just a couple of moments for more people to trickle in, and then we will get moving. Right, looks like that participant number is still steadily increasing, so we'll wait just another moment. Alrighty. Welcome to today's webinar on moral integrity and the COVID response workforce, innovations in addressing moral distress, injury, and resilience. Just a couple of housekeeping slide or notes before we begin. All participants will be on mute throughout the presentation. We ask that you use the chat function for any technical issues you may be experiencing. The Q&A box is available if you have any questions for our panelists. It will be monitored throughout the event, and our panelists will be able to answer in real time. Please note that this webinar will be recorded and available after the event has concluded. We will send out a link in a follow-up email. And we will also have a survey following the webinar that we ask that you complete and give us feedback about how you thought today went. Without further ado, I have Matt Winia presenting our speakers.
Thank you so much, Courtney. And it is such a pleasure. First of all, it's been such a pleasure working with the Center for Health, Work, and Environment on this series of panel discussions around ethical issues in the pandemic. This has been going on now for, gosh, 7 or 8 months. We've done 4 or 5 of these, and every one of them has been, if anything, a little better than the last. And I expect today's discussion to continue that trend. So we're very excited to welcome a broad and diverse group of panelists today to talk about an issue which was obviously a big issue before the pandemic. People were concerned about doing research on and exploring interventions to address burnout, moral integrity, moral resilience, moral distress for years before the pandemic. And yet, as with so many of these other sort of social issues in health and well-being in our country, this has been one of those things where the pandemic has really shown a floodlight on an issue that was simmering along, bubbling, disturbing, and yet, many of us were able to continue our daily lives without thinking too much about it. And now with the pandemic, it has really risen up as an issue that demands greater attention, and so that's the set of issues we're going to be speaking about today. To do that, we have pulled together the following individuals, and I'm going to do a very brief introduction. They obviously each have long bio sketches, but I'll start with Karen Jones. Karen Jones is the clinical nurse ethicist at Children's Hospital of Colorado, where she does moral distress rounds. Her background is in intensive care, neonatal intensive care nursing. Dr. Mark Moss is the Roger S. Mitchell Professor of Medicine and head of the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado School of Medicine. And Mark's research is on wellness among people in the ICU, as well as a number of other things that I won't get into around pulmonary medicine. And what really brought him to the table today is his really extraordinary research on the intersection of arts and humanities and well-being. Next, I have on my screen Cinda Hilton Rushton. Dr. Rushton is the Anne and George L. Bunting Professor of Clinical Ethics at the Johns Hopkins Berman Institute of Bioethics and in the School of Nursing. She co-chairs the Johns Hopkins Hospital's Ethics Committee and Consultation Service, and she has been doing research in this arena for a long time. We'll just say a long time. Almost since the beginning of research on this set of issues in moral distress. Next, I have Courtney Welton Mitchell. Dr. Welton Mitchell is trained as a social psychologist and a mental health clinician. She's a clinical assistant professor in the Department of Environmental and Occupational Health at the Colorado School of Public Health, and her work is largely in the public health preparedness and disaster response domain, where she too has a record of research and an interest in how people come out of disasters, both with trauma, experiences of trauma, and with sometimes greater resilience. So I am gonna start with Dr. Rushton, because I think, as I alluded to, you've been in this space for a long time, and my broad understanding of the field is that in many ways, while it came maybe originally out of sort of military experiences, military medicine, if you will, it was the nursing profession that really began exploring moral distress 20 or more years ago now. And I wonder, could you give us, in a relatively brief format, sort of the history of how people have thought about moral integrity of healthcare workers and the stresses that are placed on that moral integrity? The language we use around this has changed over the years. The people we think about as experiencing moral injury or moral distress has changed over the years, and the interventions have changed over the years. And I think you're probably best suited to give the broad arc of the historical progression of how we think about this set of issues.
Thanks, Matt. Gosh, that makes me sound really old.
I was trying so hard to avoid that.
I guess I am. So it's really great to be here, and also to really pause and take stock of the moral burden of this pandemic. And I think your point about how we've thought about this territory, I'll just talk a little bit about how my own thinking has evolved from the very beginning. I wrote an article in 1992 about clinicians suffering. And at that point, we really weren't talking a lot about moral distress. We were just talking about the parts of our work that were sort of residual, that we didn't quite have a way to name or even think about. So then from that, around that same time, Andy Jameson had started writing about moral distress, and we've continued to try to explore this territory, a lot of it in nursing. I think in part because of the position nurses have in the healthcare system, is that they are often in the interstitial spaces. They are carrying out the decisions of others. And so their sense of agency is constrained a lot of times. As we've thought about that even more, I know in my own work, I began to go back to thinking that maybe we needed a bigger umbrella than just moral distress. And so I found myself going back to a broader sort of notion of moral suffering that is about the anguish that we experience in response to moral harms or wrongs or failures. And that each of these kinds of moral suffering, moral distress, where we think we know what we ought to do, there's constraints, we can't actually act on it, that definition has been challenged and expanded and discussed in many, many, many different ways. And the nuances of it have I think, evolved. But what's also happened alongside that is that in a way it may be a continuum where we experience first a kind of moral stress, where we realize something's wrong here. I may not know what it is. It's igniting a sense of, I need to explore this and figure out where this tension's coming from, to moral distress. But now we're talking about moral injury, which is a concept that began in the military that has been really researched in that context. And the way I think about it, maybe not the only way at all, but it's the intensity of the sense of violation of our wholeness, our sense of integrity. And what's different about moral injury is that it often occurs in high stakes situations. And if you think about the pandemic, it's a perfect example of a high stakes situation. And it involves situations where people feel that they either perpetrate or they witness or fail to prevent an act that transgresses their deeply held values. And often it occurs in response to severe and unmitigated transgressions, often that we have no control over, but result in a sense of betrayal. And the other part that is referred to in the military is that the awareness of this often occurs retrospectively. So if you think about a crisis, we're in the middle of it, we are doing things that we wouldn't normally do, we are pressing forward, and then we finally get to the place where we can exhale and we realize what has happened, what we have participated in, and then we begin to appraise ourselves, often in a quite harsh way, in a way that can result in a kind of dismantling of our moral identity. And I have to say, I've heard this in my clinician colleagues during this pandemic, where people have said, I don't recognize myself anymore. I don't know what it means to be a good nurse or a good doctor, because I've had to do things that are so contrary to what I would normally do and that are a violation of my professional code of ethics. So I think there's a continuum, and I think we're trying to figure out how do we think about that whole territory. My work also, about 5 or 6 years ago, after focusing on the problem, I began to ask, and what else is possible? Are we just left with being distressed and discouraged and feeling violated? And so that's when I began really trying to understand and conceptualize the concept of moral resilience, which is the ability to restore or preserve our integrity in response to a whole range of moral adversity. The conceptual thinking around that was that moral resilience could be a resource. And we have been doing some research during this pandemic, 2 different studies looking at the relationship of moral resilience and moral distress, and moral injury and moral distress and moral resilience. And our preliminary data confirms that moral resilience actually is a protective resource, that it reduces the intensity of both moral distress and moral injury. And so there's something there about how we can actually not to suggest that people are deficient, but that there's something to work with that can be actually amplified and strengthened in response to these situations, not to overlook the very real sources, but to give people some resources to meet those challenges in ways that don't leave them completely disabled.
That is such helpful background, and I have a half a dozen things I'd like to follow up on, but I think instead what I'm going to do is transition and take the piece you just said about moral resilience and ask Dr. Welton Mitchell if you could maybe comment on that aspect of this, because your work has been in the disaster arena, and you know, this pandemic is a disaster, but it's a slow rolling disaster. It's playing out over, you know, a year and more now, unlike a hurricane. But you know, some of what you've looked at is so fascinating, because there are folks who probably assume that if you go through a really traumatic experience, you're sort of damaged by that. And yet there are also people who come out the other end of really, truly traumatic experiences with greater resilience, and with an even improved sometimes sense of well-being. And I wonder if you could reflect on the lessons maybe learned from the disaster sciences and the experience of people in traumatic disasters, and can we apply some of that to what's happening now with health workers and their sort of grief, regret, distress experiences.
Thanks so much, Matt. I do think that this is, really interesting and edifying for me, and I appreciate the opportunity to be part of this panel because, I started out working as a mental health practitioner, working with people who had experienced traumatic stress and disasters. And then I went on to become a humanitarian aid worker, working in a variety of different contexts, including refugee camps and elsewhere. And ultimately, really shifted more towards research and intervention research and training. And, it was actually it was 2011 and 2012 when I was hired by the United Nations High Commissioner for Refugees to do a global evaluation of their staff care needs, as well as their current response and how that stacked up against what we knew at the time to be best practice interventions. And so part of what we were seeing through that was, we collected data through an online survey and also remote interviews and in-person focus groups in Bangladesh and Pakistan. And this was with local, national, as well as international staff. And, we were sort of walking with a bit of unknown gaps that in hindsight are very clear, right? Because we were talking a lot about compassion fatigue, burnout, secondary stress, vicarious trauma. And when we were asking humanitarian aid workers what were their primary sources of stress, we were coming from a kind of historical acute stressor model, people that had experienced kidnappings, shootings, bombings, other events. But then we started to see it was more about chronic stress. And then when we started to unpack that, we saw, in fact, they were saying they felt, unable to contribute to decision making. They felt that they were witnessing terrible suffering. There was a huge scope of need, and there were very limited or wasted resources. They felt, at best helpless, at worst complicit. Their core ideals, the reason that they got into humanitarian work, was violated on a regular basis, that they felt ill prepared and had unrealistic expectations, and that there was a lack of institutional support and acknowledgement. And that this was really resulting in them experiencing, not only kind of a host of negative psychological outcomes, but a lot of guilt, shame, self-blame, self-recrimination. And, at that time, we didn't really think about framing this as moral injury and moral distress and the implications around moral resilience. There was a literature that we could pull from around benefit finding, meaning making, post-traumatic growth, but it didn't really address the core underlying ethical violation component. And so I think, kind of in retrospect and moving forward, we see in the broader disaster and humanitarian literature, there is actually one organization in particular, MSF, or Doctors Without Borders, that has done a really excellent job, only, really emphasizing this increasingly in the last few years, of naming it, addressing it, and putting interventions in place at a systemic institutional level, where these are interventions that are designed to increase institutional accountability and transparency, but also to provide the skills and institutional supports to encourage people to be better prepared, to address and recognize and get the supports they need around this kind of moral injury or moral stress or distress. And I think that, to me, that sort of, maybe in a, kind of backwards way, addresses your question about resilience, because I see the MSF response as a form of institutional response to promote resilience among their workforce that really addresses much of what historically we were a little unclear about the need to have, kind of a separate intervention framework beyond some of these other sort of, individual therapeutic and peer support-based frameworks that were really addressing what we were calling, secondary or vicarious trauma.
Yeah, that's such a really nice segue to where I was hoping we would go next, which is some of the sort of interventions that folks have looked at over the years to try and address this phenomenon of a uniquely ethical, moral component of the stress that you expect to experience in a disaster. Right there are pieces of being. So I'm going to go to Karen Jones next. There are pieces of being an ICU nurse that are inherently distressing. Watching a child die is going to be distressing no matter what. But there is also this specific component that Courtney just raised that is ethical in its nature. And you at the Children's Hospital of Colorado, you've been doing moral distress rounds for a number of years now. I actually don't know how long that goes back, but it has been an effort that's explicitly to address this ethical component. And I wonder if you could just say a few words about that as an intervention. The act of naming and talking through these experiences together with folks who have some shared experience in this. What do we know about that as an intervention?
Thanks, Matt. I love going third because that was so fascinating that she was talking about interventions just like we talk about in moral distress rounds. And as Cinda said, I've been doing this a long time, probably at the beginning of the moral distress work. I can remember my first moral distress rounds. I didn't know it at the time, but it was in the 1980s when I felt like something was not done properly. There was something wrong. There was something I should have done differently. And I had a conversation with a physician, and it sparked something in my brain in that we're in this together. There's a different perspective. I need to be open to that, possibility. And so that laid groundwork for years of sort of working with teams to think about this. And then moral distress rounds, Heather actually brought moral distress rounds to Children's. So I've been officially doing it for about 2 years, but unofficially I've been participating in moral distress rounds my entire nursing career, as most of us have, as we start to kind of think thoughtfully about what's going on. So moral distress rounds at Children's Hospital is a specific planned meeting. It is facilitated by our ethics consult team because there is an ethical element to moral distress rounds. So we feel we should own a piece of these discussions. It's interprofessional. It's like many different meetings in that it's safe, it's confidential, it's facilitated in a way in which everybody's voice is valued and heard. We really encourage all of the people in the room to speak to what they feel should be the right thing to do, right? What is the morally distressing aspect of this patient care that you are feeling like there's some sort of impediment to fulfilling what you believe is going to make you the best nurse or the best RT or the best chaplain? We talk about the tensions, right? What are the ethical tensions? What are the values that are in conflict? We want to acknowledge that there's many different points of view in the room, many perspectives. What is the patient's perspective? What is the family's perspective? Why is the physician feeling this or the nurse feeling this? It's very much a dialogue. But then we move into solutions. We move into helping everyone in the room understand that they're feeling powerless, but perhaps there are some ways to step into moral agency, either at the patient, the unit, or the system level. It can be simple. It can be, how can we help alleviate the pain that we feel the patient is suffering from? Or it can be much bigger in a more unit systemic issue. So that's really what we attempt to do in our moral distress rounds, is to have strategies and a plan moving forward. How are we going to implement these strategies? And these strategies are at the patient level. It's not a self-centered sort of experience. I mean, I'm feeling moral distress, but my moral distress is going to get better when I'm doing something for the patient, when I'm feeling like I'm enacting my code of ethics. to the best of the ability of the situation. So what we know about moral distress rounds and what we know about trying to mitigate moral distress is that, as both of our panelists have mentioned, it helps to name it, right? Just simply saying, I'm morally distraught, I'm feeling this, and hearing that the rest of the team is also feeling morally distraught. They may feel it from a different perspective. I, as the nurse, may feel it one way, and then the provider may feel it because, as you said, I'm doing the orders, you're writing the orders, right? But we both might be feeling distress. So talking about it amongst our interprofessional colleagues, we can build sort of a team cohesiveness. It can really improve the ethical climate of a unit to have these open, facilitated conversations. We know that stepping into moral agency can often help mitigate moral distress, that taking action can help us. We know that ethics education and ethics skill development, so learning about ethical sensitivity and ethical reflection, and having a conversation that is facilitated by an ethicist where we can actually address some of the ethical components, can help move people from that shift of powerlessness and this is my narrative and this is how I think about it, and they have a different perspective. They open up their eyes and see, I may not choose this, but I can understand why the patient is choosing that route, or the family is choosing that route, or this is the best of the options that we have to offer. And so we have learned some things from our moral distress rounds that they do seem to help. We have some work to do, some more research to be done, of course, as it's only one tool in our toolbox as far as helping alleviate the distress, but we know that units and work environments ask us back. And so it must be helping at least at the level of the interdisciplinary team and hopefully at the patient level too.
This is raising so many questions for me, but I do want to bring Dr. Moss into the conversation before I sort of start looping back around with the things. I will also, by the way, say the question and answer function is available. We will get to audience questions in a little bit, so if you have questions that you'd like to put into the Q&A, feel free to do so. So Mark, I think it's undisputed that there is perhaps no group of health professionals who are more attuned and more experienced in distress than people working in an ICU. This is where a lot of the original research on moral distress came from. And the work that you've been doing at CU here on the sort of cutting edge of using arts and the humanities almost as tools, and it preceded the pandemic, I should point out. This is not something you just discovered recently. Like Cinda and like Courtney and like Karen, you've been in this space for quite some time. I have to say my gut reaction, because I like art and music and so on, is to say, obviously, if you can get someone to do art, to write, to practice music, that will be soothing and will help to alleviate some of the distress of the daily, of the work environment. Are there data to back up that gut reaction? What do we know about the link between arts and humanities and work life?
Yeah, there's not, Matt, a lot of data. This work is funded by the National Endowment of the Arts, and what they were interested in doing is taking a research approach to generate the data, because everyone does have the gut feeling that you have, Matt, that it seems like it would make sense. It sort of is a natural thing that we would all expect to be beneficial. But what the National Endowment of the Arts wants is data. Like, we all want data, so they can go to Congress and other groups and say, no, this really works. Like, the arts are really important. I think there are a few issues here. I think the first thing to build on what Karen said a little bit is some of the work one of my colleagues, Meredith Mueller, did is she did qualitative interviews with ICU nurses, and we identified nurses that were resilient and nurses that had symptoms of PTSD. And when you ask how they respond to different, or respond to the same situation of a patient dying, the nurse who has PTSD ruminates about it and says, you know, I noticed their arm was a little swollen. If I just told the doctor that, you know, maybe they have a DVT in their upper extremity, maybe the person wouldn't have died, or maybe if I'd noticed this, and they keep thinking about what ifs. Where if you ask the nurses who are resilient, they approach it that the person was very sick. Unfortunately, the patient was going to die no matter what we did. And we helped them have a more comfortable death. And we really helped the family through these difficult situations. So they take the same situation and view it in a different way. And I think that's one thing that we're all trying to figure out is how can we reframe things so that we look at the same situation, the tragedy and suffering that occurs in intensive care units, unfortunately, is not going to go away. People are going to die in intensive care units. It's part of what we do. It's not the only thing of what we do. Many people live too, and we do a lot of great work, but it's something that's inherent. It's an occupational health hazard of working in an intensive care unit. So if we can learn how to reframe these situations and see the good in it, I think that's an important strategy or intervention. In the same way, I think there's a way of restoring ourselves or revitalizing ourselves, especially in this day and age where the barrier between work and home, especially since I think many of us are sitting at home right now, or some of us, and working. So how do we keep our work and life outside of work somewhat separate? It's even harder now when many people are working from home. So I think one thing that's important is to come up with a transition, figure out how to leave work behind in a positive way, and restore ourselves as we transition to home. One example of that, which I think is interesting and a little related to this, is that 100 years ago, hospitals were all next to gardens, and people would go for walks in the gardens. And I can tell you that Duke's hospital is right next to the Duke Gardens. And if you talk to people that work in that setting, they'll often revitalize themselves by walking through a garden on their way home and sort of saying, I'm leaving work behind, I'm transitioning back to my life outside of work in a positive, healthy way. In the same way, getting to the creative arts side of things, and I'm a critical care doctor. I'm not the most artistic person, but this is where strong collaborations work. And there's a very strong creative arts therapy program that Karen, I'm sure, knows about at the Children's Hospital of Colorado that works with patients there. So I reached out to the leader of that program, Catherine Reed, when we were thinking about putting this application into the National Endowment of the Arts, and said, how can we come up with this? And in conjunction with Michael Henry and the Lighthouse Writers Workshop here in Denver, we came up with kind of strategies and theories of how creative arts therapy could be effective. And kind of the bottom line, Matt, is that sometimes we don't have the ability to describe or process or kind of express our feelings about events verbally. It's just hard to talk about these things. And what we can do is through nonverbal interventions, creative arts therapy, which I'll explain in a second, can help people access, explore, share authentic emotions through visual, musical, physical, and written forms, because they're having problems how to say what they're feeling. And by reconstructing the meaning through these processes, the participants or the healthcare professionals can confront, reflect, and better cope with the traumatic experiences that Cinda, Courtney, and Karen discussed. And kind of at the same time, I think an important component of this, especially in the pandemic, is, my God, how isolated is everyone feeling right now? I mean, you can't do anything. If you wanted to go to a movie, if you're the person who goes to the symphony or to a play or out to dinner or go to the gym, that was all shut down and people felt very alone. I think that's been part of working in an intensive care unit because people didn't feel comfortable talking about these experiences. It was perceived as a sign of weakness, that there's something wrong with them, when everyone's feeling the same thing, just people didn't feel comfortable saying it. So I think in addition to what our program could do, we hope it does, is by giving people this opportunity to express themselves in a safe space in a community, it can build deeper relational bonds with the people at work with a therapist. This is not just, I'm going to go paint. This is through painting with a creative arts therapist to learn how to better understand and cope with the stresses that unfortunately we all deal with in a work environment. The other thing I would say is that this project started out before the pandemic as focusing on critical care healthcare providers, because that's what we do. But once the pandemic came along, we realized the whole world's stressed out. Clearly, all healthcare professionals are stressed out. So we open up the inclusion criteria to be all healthcare providers. And for like the first time ever, trying to do a clinical trial, we have a wait list. We have people that like, I want to get into this because I think it shows there's clearly a need, and people need this outlet. So is there data, Matt? Hopefully when we're done with all this, there will be. And I think, as I said, it's what the National Endowment of the Arts wants in a very positive way, is they want data so they can really say that this stuff works and get the funding for it, similar to what they do in England, which is, I think it's really interesting. So if you go to your general practitioner in England, they can write a prescription for you as a patient to like go to the symphony. I mean, how cool is that? That's part of a prescription. It's not just like, oh, here, take a medication. It's sort of like, why don't you go to the symphony? Why don't you go to the play? I think that will help you in all the ways I just talked about.
I've heard someone else talk about giving prescriptions for books as well.
Yeah.
Like I prescribe you to read this book. Next visit, we're going to talk about it. I have two questions that I think are kind of controversial, but I do want to explore them. And one, I guess I'll go back to Cinda on this, although I think others will maybe want to jump in. And that is this issue of moral resilience. And I think sometimes we talk about moral resilience as a character trait, and sort of something that you either have or you don't have. And it's a predictor of how you will respond when placed under moral stress. But in other ways, I think we have thought of moral resilience as something that you acquire and that you can actually build over time. And I wonder if you could just reflect on how you think of moral resilience these days, Cinda. Is it something you acquire through your childhood, and by the time you're a fully formed health professional, you're kind of done and we have to figure out how to help you cope with what you've got? Or is this something that you build and refine over the course of a lifetime? How do you think of moral resilience?
Well, it's very interesting how you framed that, actually, because, and this is, obviously there's more than one way to think about this, but the way that I've thought about it is sort of the idea that we are all whole to begin with. We come in as whole people. We all have resilient potential. And that, there's this, it's not as if you have it or you don't have it. The assumption is that we all have it, and that there's an opportunity to amplify and strengthen that. And if you look at the resilience literature, it's often a process that occurs in response to some kind of adversity. So in this sense, you know, it's the moral adversity. That's, we meet those challenges, and through that, we're able to hopefully grow as a result of it. So in my thinking of it, it's not an appraisal of whether you're moral or whether you are resilient. It is rather that the assumption that there's nothing broken. It's just about how do we strengthen our capacities to meet these challenges that exceed our usual methods of meeting them. So it's not a deficit model, is the first thing I'd say.
Yeah.
It's a strengths-based sort of approach. And, you know, the image that I like to use about moral resilience is the process of kintsugi that is used in Japan, which is, you know, instead of taking a piece of pottery that's broken and discarding it because it's broken and no longer usable, to be able to use the opportunity to say, we're going to put this back together, and we're not going to hide the broken parts. We're going to see those as integral to who we are and to our sense of integrity, really. It's not turning away, but turning toward and honoring that with the possibility that we might be able to create something new as a result of that, that honors those pieces, rather than turn away from them and say, well, I just failed. You know, I was ineffective. That's how we learn, I think.
Did anyone else want to say something about this concept of moral resilience and how it evolves or builds? Before I have another question that may derail us, so I don't want to leave that before others get a chance to comment if they want.
Matt, if you don't mind, I'd like to comment. You know, I spent a lot of years as an individual mental health practitioner and thinking about traumatic stress and resilience and working with people on coping skills, reframing, meaning making, building up formal and informal social support, working on cognitive flexibility. And I think those things are all still incredibly important. But I also feel like more recently I've shifted to that institutional model of responsibility and thinking about, you know, again, that MSF or Doctors Without Borders example, you know, they have a multi-stage model that they're utilizing and evaluating currently, identifying ethical dilemmas, consulting with employees in a safe space around ethical perspectives, providing transparency and ultimate decision-making, and case study discussion. Lots of use of case studies at the organizational level. For example, they have a great publication looking at a number of different ethical dilemmas that arose that directly impacted employees in the context of the West Africa Ebola response. And then also a focus on managerial training and ethical review, oversight, and accountability. So I think that, you know, when we look at some of the risk for adverse outcomes in terms of moral injury, that is often related to, while there are numerous factors, one of them is this idea of a lack of institutional support, oversight, or guidance, and an expectation of individual level decision making in an immediate ethically challenging circumstance. So I think that, you know, for me, I've tried to kind of marry the two components, that individual level therapeutic response with this other component that really is not losing sight of the broader institutional framework and accountability.
Matt, can I say something on this point? Because I feel like it gets misinterpreted over and over again, that if it's an either or mindset, that you're either going to focus on the individual or the system. I have never advocated for either or. I think it has to be both, because our systems are full of people, and we need to provide supports individually and systemically to support the well-being of individuals in those systems. But the reality of system change is it doesn't happen overnight. And so we've got to have resources to help people be able to meet the challenges. And Mark, I always appreciate your what's modifiable and what's not. You know, what are the pieces that we can begin to dismantle is really, really important. So Courtney, I 100% agree with you. And I think it's a kind of disservice to suggest either or is the way we have to think about it. I think it's both and personally. And so we need the whole thing to be able to make progress.
Yeah, you're reminding me, Cinda, when I was growing up, my mom always had a thing on the wall that was the Irish Serenity Prayer, right? The one about change the things you can and the wisdom to know the difference. Is there, this is a very practical question before I jump to the one that I think might derail us. Is there a difference in talking or thinking about moral distress when you're still in the situation? Maybe Karen, you might be best positioned to help me think about this. When you were describing moral distress rounds, one of the things you said is that you could use the rounds to help people figure out how to address the situation as it evolves. And I'm wondering, is there a difference between addressing moral distress retrospectively, when you're no longer in West Africa, you're home now, but you can't sleep nights, and addressing a case that is evolving in real time in an ICU? Do you think about those differently?
Yeah, definitely. I think that when you are doing a real-time moral distress rounds, you are thinking about things that you can change, some solutions that in the immediate time frame, maybe we can change something at that patient level. When you've heard about a situation that was really morally distressing, and the team is still thinking about it, they're, like Mark mentioned, right? They're still ruminating. Getting together and still hearing those perspectives can still really open up your mind to maybe that that narrative that I was telling myself is a little different, or I'm going to figure out what is mine to carry, and recognize, okay, that was a really morally distressing situation. Here were some things maybe we could have done differently, and when it comes again, which it will if you're an ICU nurse, I'm going to do something differently. I'm going to raise the question earlier. I'm going to, bring the team together. So you might not change that particular patient situation, but you can certainly think about the case differently, work together as a team to really support each other. Like, that was hard. That was really hard. And then, prospectively, what would we do differently? I mean, there's a lot to be learned from what could we do differently, just like we do in M&Ms. Very similar. We're not going to change that outcome, but we certainly can change how we're triggered the next time that case comes forward, and jump on it sooner. So I think they're both valuable.
Yeah, so this actually is a nice segue to where I wanted to go, and that is the really early work on PTSD found pretty strong correlations between people being involved in atrocities and suffering PTSD later. And it strikes me that there are undoubtedly people who have moral distress for a very good reason. They did something wrong. And there are others who feel like they should have done something differently, but really they couldn't, right? They honestly did the best they could do in a terrible circumstance, and everywhere in between. And I wonder if we're seeing that kind of a link. And you opened the door to this a little, Karen, by saying that, what could you do different next time? Which implies that maybe you actually didn't do everything you could have done the first time. Maybe you did make a bad decision the first time. And are there different approaches that you use or think about when you're dealing with someone who's experiencing moral distress because they actually, in a terrible circumstance, under stress, without enough sleep, hungry, had to go to the bathroom, and they ended up making a bad decision, one that they now regret, versus someone who truly was constrained and required to make a terrible triage choice, right? And even thinking back on it, they might not make a different choice, but they're still haunted by the choice.
Matt, I think there's something fundamental about this. So I don't think it's just the moral distress issue, at least for what some of us do. So I mean, I can just give you an example, and we all have these experiences. We all have these nightmares. Where back in May, a 35-year-old guy came in with COVID. He was otherwise healthy. And despite excellent care, he decompensated and went from talking to him to being dead in 8 hours. We didn't do anything wrong. He got great care. That's not always the case. And then his wife was allowed to come in and see him. He had 2 small children that his brother was sitting, someplace else with. And his wife became so hysterical. She fell on the floor and was crying like a wounded bear, inconsolable that her husband had died. No one had done anything wrong. There was no moral distress. It's just we see and experience very difficult things. And to me, it gets back to what Courtney was saying, working in refugee camps, or being a social worker. We have very difficult jobs, and we see things that and experience things that other people, fortunately or unfortunately, I don't know what the right word is, don't. And what happens is we have to deal with that in addition to when, as you said, maybe you think you did something wrong or you missed the this or that, which is very important. But I think even without the moral distress, there are difficult situations that we have to deal with as healthcare professionals. And I think those things were not always addressed. And what I always used to say is that if I printed out my patient list and I knew there was one patient that was really sick, and I went over to see the patient before we started rounding, and I asked the nurse, how's Mr. Smith doing? And she says, oh, Mark, he passed away 10 minutes ago. When I ask healthcare professionals, what do they do with their list? The majority of them cross the name off the list. And some of them will admit that they'll say, wow, now I only have 12 people to see, not 13. Those are some of the issues we have to deal with.
Yeah.
Mark, can I just say something about what Mark just said? I think your description is such a profound example of unfortunate and uncontrollable outcomes versus actually, anything that we could have possibly done to have changed that outcome. And what's interesting is that clinicians hold ourselves responsible for things that are largely out of our control, even though others looking in on the same situation wouldn't. And so there is this piece of our own appraisal of expectations, I think, of ourselves, that we have such high standards and somehow expect perfection when it's totally unattainable. And I think that's another piece of the puzzle of how we, what we carry in terms of responsibility, and then associated with that is the guilt and shame and blame that may not actually have anything to do with external, but that we extend to ourselves. And that's a whole other dimension, I think.
Yeah. I wonder if is there something we ought to be doing in medical training? And I'm thinking about this in part because of the fact that as people come into medical training, they have moral formation that's already taken place, but then they become health professionals. And there is a moral development that arises as you learn what it means to be a good nurse or a good doctor or a good respiratory therapist. And I'm wondering if sometimes there are conflicts between your sort of native moral development and the moral development that arises as you become a health professional. Is there a component of moral distress that can be alleviated by helping people to see that, yes, you did the right thing as a good nurse, even though it felt bad to you, you know, and because of how you were brought up, because of your, you know, religious beliefs, etc. I saw a story about this the other day in the AMA Journal of Ethics, where one of the cases they were looking at was around a student who had very strong religious beliefs and a patient who chose to forego ongoing chemotherapy and chose hospice, and the student felt terrible that they had done something wrong. They had inadequately convinced this person to press on because you know, that's what they would have done. And it struck me that, you know, we all sort of go through that moral development process of coming to realize what it means to be a good doctor. And sometimes it means letting patients make decisions that you would not have made yourself.
So Matt, you know, I teach pre-licensure students, and I think what you're pointing to is really professional formation, and there is clearly a moral dimension to that formation. So one of the things that I think is often missing, particularly, we've just launched a program here in our state, looking at how we can build resilience and ethical practice in students, faculty, and new nurses. And part of it is really on this point of how do we begin to create the foundation that can be then developed over time. So one of the things we do in our class is we start out with values clarification. And what's interesting is a lot of people have trouble naming what their values are, either personally or what the values of our profession are. So then from there, to begin to explore how do we use these tools of moral reasoning and thinking to approach some of the kinds of questions that are going to come up. And so we do that through debates. And I have to tell you, I love these debates because they have to prepare for both sides of the equation. And they have 5 minutes to present their position and 2 minutes of rebuttal. And they have to use these tools, which include their code of ethics, you know, principles and theories, and evidence to support their point of view. And then, you know, there's the being able to put that into practice. And, you know, the idea Courtney was bringing up, the case-based work, I think we have to make it explicit and not think that, oh, this is just one module in professionalism. There's something more than just saying, oh, now we're going to do ethics and seeing it as part of everything that we do rather than this add-on thing, you know, when you're all done, you can do your ethics. So, Mark, I don't know, in medical training, or Matt, either one of you, you know, similar?
Well, one of the reasons that question came to my mind is because of something Mark said earlier. I think we don't get very explicit about the fact that during the course of medical training, you will see and witness suffering. And one of the consequences of that may be that you become inured to human suffering, that you become hardened, and that you start just crossing people off the list and saying, oh, 12 instead of 13, it's a better day already, right? That could happen to you. And some degree, it probably will happen to you. To some degree, it probably has to happen to you, because in order to be a good doctor, you have to be able to compartmentalize the suffering of one patient such that it does not affect how you treat the next patient, right? You can't be destroyed when you see someone suffer if you plan to go on and have a productive rest of your day. And by the way, those other patients need you. They need your full attention, undistracted by the fact that you just witnessed something terrible. So we train people implicitly to become inured to human suffering and to move on. And I don't know how much we talk about what the cost of that is. and how to ameliorate that cost over time so that you can maintain your humanity, your empathy, right? These are that balance of becoming, of some, developing professional distance, we call this sometimes, and yet still having empathy and humanity is something we don't, at least, outside of small group discussions, I don't think that gets explicit attention, but it certainly is taught implicitly. I don't, Mark, what's your experience with that?
Yeah, what I would add to that, and I've never studied this, but I think it's true. I think this is what anatomy lab's about. So in medical school, the first thing you do, first year, first semester, you have anatomy lab. And in the beginning, you walk in, you're like, oh my God, this whole room's filled with dead bodies. It's kind of weird. You're afraid you're going to pass out or something. And like, at least for us a long time ago, the head was covered. And you start dissecting the arms, and you kind of get a little used to that. And though you weren't supposed to, then you're eating lunch in the anatomy lab, so you've gotten used to being there. And then they finally take the cover off the head, and then you see the person's face, and it's a little weird again. But by the end of anatomy lab, and it almost was like a ritual in a very strange way, you had to take a saw and cut the head in half to then dissect the inside of the head. So I think what anatomy lab, as I've said, it's not about learning the 23 muscles in the forearm. It's learning how to depersonalize. And I'm not sure that's totally the right way to deal with these issues. But Cinda, I think that's the way people dealt with it for the last 100 years. As Matt said, you can't cry hysterically every time something happens and not be able to take care of your other patients. But that process through anatomy lab as an example, or crossing names off a list, I'm not sure that's the healthiest way for us to care for ourselves so we can care for our patients.
I do want to turn to the audience questions. We have, by my clock, roughly 30 minutes, a little less, to go. So the Reverend Ann Dondapati Allen is keeping track of questions in the Q&A. So I'm gonna get, this is your heads up, Annie, that we're about to turn to audience questions. Do you have something lined up? Because otherwise, I do have one more that's sort of controversial I would like to get to. But let's do an audience question first.
Sure. So we have some great questions coming up in our Q&A. I'm going to try to group them according to some similar themes that are coming up. And one of those has to do with systemic change. And really folks looking for some strategies, some thoughts that you might have on strategies for how do you go about creating systemic change when the healthcare system is causing or worsening moral injury, and moral integrity being an issue in the healthcare system in the US, and how, and if there's a way to build team resilience, which you've mentioned as a protective factor. It is a very big question, a large question, but if you have any strategies that you can offer for folks, I think they'd appreciate that.
So this sounds, Cinda, like a spin-off of something that you mentioned already, which is this is not either or, it's both and. We need individual resilience building strategies. We also need team and organizational strategies. What are some of the, and Courtney, I think you've alluded to this as well. So I'm not sure who wants to jump in, but anyone can here.
So, I think we've alluded to some of them. Some of it is surveillance of what are the factors that are contributing to the distress. And again, I always use Mark's modifiable and unmodifiable, sort of framework, because some things we can't easily change, but there are plenty of other things that we can change. So for example, during the pandemic, clearly, one of the things that contributed to a lot of distress were visitation policies, were lack of PPE. There were people who were working in unfamiliar places and worrying about causing harm. So there's the policy piece when we implement a policy to actually look at the unintended consequences. So one of the unintended consequences of lack of PPE at least in institutions that I'm aware of, resulted in limiting the number of people who went into the patient's room. So that meant that nurses were the ones that went in for 12 hours with their PPE, while other people stood outside the window and looked in. That began to become a source of betrayal. Like, why are we the ones who are taking the disproportionate risk? So tracking those patterns, and through things like Karen's talking about, we did moral resilience rounds, just a difference, sort of wanting to orient toward something hopeful. But similarly, trying to look at, what are the system contributions to this particular issue? And are there things we could do something about it? Having forums where people can come together and in a psychologically safe environment, bring what they are carrying, have it witnessed and honored in a way that is not judgmental and allows people. Courtney said one of the key elements of moral resilience is moral efficacy. Do I see myself as capable of meeting these challenges, restoring our sense of agency? That is another piece, having places where people can speak up and there's not retribution for saying, this is a problem that needs attention. I think all of those are really important from a systemic point of view, but I also think there's bigger issues that the National Academy's report on burnout pointed out. Our financing, our electronic medical record, all manner of other things that are very much more difficult to change quickly. But I think, I think there's probably lots of other examples. I don't know if Courtney and Karen maybe have some others, or Mark.
I would be happy to just reflect on some of these issues in a different systemic context, thinking about the broader humanitarian infrastructure. There's a lot being done around recently collective experience, validation, understanding, action, and advocacy around decolonizing aid and addressing systemic racism and acknowledging some of the problematic structural frameworks, for example, differential treatment for international versus national and local staff, and that comes up across a lot of different contexts, whether it's salary differentials or in the context of the West Africa Ebola crisis, who could be medevaced, who could be given certain access to treatments. And so I think when we think about, holding systems accountable and collective advocacy for systemic change, there is often safety in numbers. And, whether that's a teachers union advocating for change within the educational context or, other staff-based unions and initiatives, I think that in some ways protects the individual from, adverse personal and immediate outcomes, which we've seen historically. People have been let go or labeled as problematic or troublemakers. And I do think that one thing that I wanted to point out that touches on this question and some of what we've covered thus far is, I think that everyone in the process of professional development and experience is calibrating and recalibrating their moral compass, but often we may be working in systems that have different subcultural norms, and those subcultural norms may, whether explicitly or inadvertently, reward things like avoidance, lack of acknowledgement, keep your head down, don't say anything, this sort of numbing, depersonalization, lack of empathy. I think that in the broader humanitarian context, historically, some people have talked about quote unquote cowboy culture, and where you're seeing like high level individuals within organizations, UN and other organizations, come forward and acknowledge issues and share their personal experience. That really does quite a lot to counter those, kind of toxic subcultural norms that can promote maladaptive strategies and have, not only negative impacts at the individual, but also at the institutional level in terms of service provision, reputation and other outcomes.
Really interesting. Annie, would you like to do another audience question, or shall I ask
Yes.
my moral question?
I think you've addressed it somewhat, but I just want to bring up one more theme. And I think Dr. Welton Mitchell, you just mentioned that while we reward avoiding the issue, there are questions about retaliation and fear of retaliation. And, you know, how do we go about addressing that? And kind of a related thing, are there moral injuries which cannot be helped no matter what? Because that seems to lead to a sense of resignation that nothing will change.
Can I build on that question? I don't have the answer to
Sure.
it, but I have more of the question, I think, which is, you're very much reminding me of work in patient safety and quality improvement, and the whole set of ideals around a just culture, the ability to be able to raise problems and so on without fear that by raising the problem, you will be, you know, that the person raising the alarm will be seen as the problem, which you know, happens too often. Obviously, the person pulling the fire alarm is assumed to have started the fire, but that's a frame that is used a lot in quality and safety. Is that frame the same one? Is it being applied explicitly in this domain of moral distress?
I think it's even deep. Again, I think it's deeper than that, Matt. I think our society has a huge mental health stigma, and these are perceived as being mental health issues. So, you know, you're going to fill out your license. You can't say you have symptoms of depression, but it's fine to say you have cancer. You can get your license renewed. You don't have to get someone else to sign off and say you're mentally competent to see patients. So there's a huge mental health stigma. And then in the job situation, I mean, Tate Shanafeld and others have done surveys of medical students and asked them, you know, would you tell your residency director that you have a mental health issue? And most of them say no. They're not gonna write me as good of a letter recommendation. So I think this is a huge issue of how we frame this, because people are framing it as a mental health issue. And I understand there are mental health components of it, but this is an occupational health problem. This is not that there's something wrong with us. And I've said in other forums, you would never, I mean, I'm a lung doctor, you would never turn to the coal miner and say, what's wrong with you? How'd you get lung disease? Like, are you not tough enough? You would never say that. You might say you didn't get the right protection and that's a problem with the company, but you would never blame the coal miner for getting coal miners induced lung disease. However, since this is a mental health issue, people are like, well, wasn't tough enough, wasn't cut out for it. And that's completely wrong. As I said, we have tough jobs. We see tragedy on a daily basis. I think we have to reframe it, because not only is it pulling the fire alarm, but it's questioning kind of who you are as a person and whether you're even competent to do the job. Who's going to sign up to say that?
Yeah, that's really interesting.
Yeah, I couldn't agree more with Mark. I think that there's a real tendency to conflate all of these things into one thing. Burnout seems to be the most popular thing right now, to call everything burnout. It's not all burnout. It may be that different factors contribute to it. I think the bottom line is being in situations that exceed our capacity. We don't have the resources to meet the demands, and we all have limits. And we have to be able to honor those limits and to allow people to say, no, I cannot go beyond this without harming myself or someone else. And that's part of, I think, creating a just culture where we're not imposing expectations on people that inherently cause harm to them. And the mental health issue, Mark, I think we've seen so many tragic examples of the shame that is associated with saying that we need help. There's a recent survey done by the American Nurses Foundation where 50% of the nurses said during COVID that they didn't really need any mental health help. 30% said that they thought they ought to be able to care for it themselves, and 20% sought resources. That tells us that there's a disconnect here in our ability to ask for and receive support and help. And so when you think about the system, I think we've got to also think about how do we make it possible. And your point about the subcultures, we've got to start paying attention to what kind of environment we are creating by our behaviors and responses.
You know, I was going to earlier ask about the sort of pros and cons of labeling something as moral. I don't know how many of you listen to The Hidden Brain, but it's become one of my favorite podcasts. And there was a terrific episode a couple months ago called Moral Combat. And in the Moral Combat episode, they really explore the sort of difficulties that arise when you label something as a moral issue. It prevents you from being able to compromise. It alienates you from people with a different perspective. And so it was, you know, it was about broader themes in American society and how many issues have become, you know, moral issues where compromise is inconceivable and where you can't see the other person's point of view because you're moral and they're not. But now you all are, and so I was going to ask, is there a downside to labeling this experience as moral distress as opposed to something else? I don't know what else. But now you're making me think the other way, which is maybe there's value in calling this moral distress rather than labeling it as mental health, right? This is not because you have a mental health problem. It's because you were in a circumstance that created moral distress for you. And so I don't know, now I'm asking two questions that have opposite directions, but any reflections on that? Is it good, bad, indifferent, or both to label this experience with this very loaded term, right? Moral is a very, carries a lot of freight.
I don't know for sure, to tell you the honest to God truth. I don't know. But I'll tell you why I think it's important is that it points to something that is, for me, it's about integrity. It's about the sense of being whole and undiminished in myself, in my relationships, in my work. And when we can, there is something about our character, about who we are and what we stand for that is central to our identity, to our sense of personhood. And so it, to me, points to a territory that is not captured by this is just an emotional response. There's something more at stake here than just I need to have better coping strategies with my reactivity. It's because something important is threatened or violated. And if we don't have a way to recognize and name those as important parts of who we are, then I think we overlook something that is pretty fundamental to being human.
Yeah, I think one thing you're making me think at least is we don't want to get rid of moral distress, right? The fact that you experience moral distress is a validation of you as a human being, as having moral integrity, right? If you had no moral distress, it might, in the type of work we do, it might mean that you no longer have humanity and compassion at your core.
But Matt,
So
you
I
bring
would
up,
agree with that. Go ahead, sorry.
oh no, that's okay. I was just gonna say, you know, Matt, you bring up a good point in that sometimes people don't want to, in my case, they don't want to attend moral distress rounds. That doesn't sound like something that I as a provider have, right? So there have been times in which we have hidden, to use a word, you know, it's a new unit, they're just sort of starting to reach out, and we've sort of hidden moral distress rounds in what we might call a case debrief or a team meeting, and they invite Karen, and guess what, halfway through, thank you for all of that, you know, what happened from a physiologic standpoint, now let's talk about why we're really feeling, why we're really here. And when you have everyone in the room and we've sort of made it a safe space and we've started to talk about feelings, you'll find that people who wouldn't have normally come to a moral distress rounds are now like, yes, this is what I'm feeling. Thank you. I appreciate this. Let's talk about it. And they find themselves in a moral distress rounds and they didn't know it. And so it's sometimes for units that you're struggling with and you feel like there might be, retribution, or you might have, people who aren't willing to come. If you can combine it with something like maybe a little bit of a case review, right? I need you, the provider, to come and bring the case information and stay while we talk about, what's bothering the nurses, and they benefit hugely. And 2 or 3 times, and now we're calling it moral distress rounds. So it's one of those words that sometimes has a connotation that we just have to walk gently, and then people are willing to call it what it is. I do like moral resilience though, Cinda. I do prefer that as opposed to distress.
If I could just follow up on something that Karen said, I think this is such a beautiful example. I mean, it's really, to my mind, about the psychoeducation and normalizing and naming and very explicitly talking about ethical and or moral ambiguity. And that is the norm often, that the ambiguity and the complexity is the norm. And how do you help people to develop the skills to navigate that complexity and not feel completely isolated, alone, withdrawn, and inclined to self-recriminations?
No.
Matt, can I just say something about your statement about do we want to get rid of moral distress? I think that moral distress is an important signal of our moral conscientiousness. What we want to get rid of are the modifiable things that cause moral distress, that we can actually remove some of the sources where we can, but that internal, almost early warning signal that is activated is very important for us to recognize that something that matters a lot to us is in peril right now, and I need to pay attention.
Yeah, it's the red, flashing light saying your integrity is being attacked here, and to recognize that, but it's only, I suppose, after recognizing that you can choose the path that you take, given the threat that you're seeing or experiencing. Annie, are there some other questions from the audience? I realize I keep jumping the queue.
There is a question that has to do with how do you, when you feel that you're very alone in the suffering and it's unique, how do you process that? Karen talked about doing moral distress rounds. How does that apply to individuals that might be going through it? And is there a space to process that?
Can I say something there, Matt?
Yeah, I was going to say, this is almost the opposite. So first we had the question about teams, and now, well, what if it's really one person who's feeling very alone? Mark, what do you think?
I think, and it's what Karen's, I think, getting at to some extent is we need to create a safe space for people to be able to talk about these things, whether they're an individual or a team. And I'm not sure the healthcare environment's always honored that. I think we're chipping away at it. But I think if people had a safe space, if you felt comfortable, and from what I understand, social workers have sort of figured this out. All this stuff is embedded in their training because social workers have tough jobs. They talk to people that work in refugee camps like Courtney's done, or child abuse or sexual abuse. I mean, they hear horrible things over and over again, and they realize they got to do something about it. So I think the first thing we need to do is create the safe space. And I think the other thing that I just wanted to say is that medicine's being run too much as a business. And if we really wanted to go to business school, we would have. But there's a reason we went to healthcare professional school. And I'm not naive, I get it's a business, but it can't be just a business. So what I would add on to what Karen and others are saying is it's helpful to talk about it and give people the safe space, but then it's got to be honored. And the way to honor it is to say, okay, instead of having clinic this afternoon or having to see patients this afternoon or whatever it is, we're going to grant you the safe space and time to address these issues. And that gets back to the individual, organizational, whatever. We got to address the issues collectively. And I think we've got to get to the point where people realize we've got to give you a safe space, make it comfortable to talk about it, give you the time and effort to address these issues. Otherwise, I'm not sure we're going to have as many people wanting to go into healthcare or staying into healthcare, especially after this pandemic. And I won't be surprised when the pandemic's over, whatever that means, that there is going to be an exodus of people from healthcare. And if we don't address it now, we're going to have big problems down the road because there's been not as many people caring for our patients.
Couldn't agree with you more. And, you know, the other part, Mark, I was thinking about your work in the arts.
Yeah.
During this pandemic, we've been working with Brian Dories in Theater of War, and Brian got funding to do 10 performances using the Greek tragedies as a way to engage clinicians as a third person experience to process their experiences. And they were incredibly beneficial. And we're continuing to work together to try to figure out how that we can expand that, because sometimes it isn't safe in your organization. And so sometimes you do need to have spaces that are outside that, you know, don't have any real connection to your workplace as a place to process this. So I really think the expansion of our thinking to include arts and other means of helping people open up different parts of themselves as a way to process these experiences really important.
As I said, Cinda, there's a reason why there were gardens next to hospitals. People realized a long time ago, and we've forgotten it, that we're more than just this robot that takes care of patients. And if we don't acknowledge the other part of ourselves and give us the space and time to restore ourselves, it's a problem.
Annie, do we have a lightning round question? Because we're coming very close to our end point.
Yes, well, I don't know that this is a light question, but I think it's a very interesting question. And that has to do with, is that moral core that we've heard about, if that's immutable? So no, Matt, not a light question, but I just wanted to offer that as something for us to think about. There are questions about, folks are asking if they can get some written materials on the topics that we've discussed, and they really, really appreciate the discussion we've had so far.
Wonderful. There are written materials. There's a considerable literature in this arena. And maybe what we'll do is ask each of the panelists to give us one or two of the key articles that they think have been, you know, or podcasts or whatever you have that's a resource. And we'll put all that together and send it out to the folks who attended as a getting started point if you want to dig more into these issues. Are there comments recognizing Annie's question from the audience is a deep question about the immutability of the human moral core? Anyone want to tackle that in the last 30 seconds?
I would just say in brief that as I said before, I think we're constantly reappraising and reevaluating or recalibrating our moral compass. And I do know for some people, for example, in a therapeutic context, self-forgiveness is really important. That might involve, you know, amends or reparations, and that often maps onto personal, religious, spiritual, cultural traditions. And so just acknowledging that piece as well, because each individual's pathway to healing may look a bit different while we simultaneously are working for systemic change.
Well, thank you all so much. This has been a wonderful conversation. It really reminds me why we moved from a 1-hour format to a 90-minute format, because a lot of the last 30 minutes has just been incredibly rich. So I want to thank all of our panelists. I also want to thank those of you who are in the audience and submitted questions. Those of you who are in the audience and had questions and didn't get a chance to submit them, feel free to send us notes, and we'll circulate them out if things come up later. And I look forward to joining with this audience again. I don't think we have a date yet for our next one of these, but we will certainly keep up this collaboration between the University of Colorado Center for Bioethics and Humanities and the Center for Health, Work, and the Environment. Thank you all. Have a wonderful afternoon.
Thank you, Matt.
Thank you.
Thank you.